All right. We are ready to roll. We've got some people waiting and ready to watch. Um, so, for New Leaf family out there who are tuning in or who are going to be watching the replay later, really thrilled to have you joining us. We're going to have a fun evening. It's going to be a good conversation. I've got Dr. Alan Trites with us. Dr. Trites is in practice in Kansas City, and he and I know each other because he does applied kinesiology and functional medicine just like I do. So we're among some of the kind of rare weirdo doctors out there. And we just have fun solving puzzles and working with people and really kind of changing their lives in a different sort of way than the usual paradigm. And so that's how we know each other. And Dr. Trites knows a whole lot about genes. And that's not an area I have really delved into. So I've had the privilege of talking to him and asking him some questions. And I just had this idea of, you know what if I could get him to show up and let me interview him and just help all of you guys out? Because a lot of you have been asking me questions about genes, lifestyle, which genes matter. Can you even do anything about the genes you've got? So we're going to get to spend some time with Dr. Trites tonight and pick his brain and learn why we care about genes and what we can do about them. So really, really thrilled to have you guys. And just one more thing I want to say. Dr. Trites has like so many degrees, I think I've lost count. He's got a few. He's been involved in so many kind of health-related, clinical-related things, and he's finishing up a bunch of training in genetics and gene testing. So he knows his stuff. So the first question, Dr. Trites, that I've got for you is really how do genes affect my health? And do I have any control over how they affect me? Like if I know what they are, is there anything I can do? Like why bother knowing?
Well, that's a good question. Do you have any control over your genes? You don't have any control of what you get. You are born with, half from your mother and half from your father, and that is what it is. But you do have some control on how they express. For instance, you're not born with a disease. Well, some people are, but very few really are born with a condition. This happens over time, and you do know some family members that might have a condition, or a relative that has a condition, but their children may not, or vice versa. Your aunt or your uncle didn't have anything, but their children did. The thing was, you all had the genes. What's the difference? It's called the expression. And this is a part of science called epigenetics. It's the expression of that gene. And so there are things that allow a gene to express. Let's say it's a gene that's non-functional or underperforming, and that's your environment. It could be your stress. It could be your food. It could be your lifestyle. It could be the medications you take. They all play a role in this thing called epigenetics. And what we're looking at as far as genes go is there any type of what's called a SNP? We like if you took a piece of scissors and you cut a piece of DNA out, thousands of years ago, our ancestors had to develop these SNPs. So they had a virus that came along that may have wiped out an entire tribe. Well, the next tribe over developed this SNP to protect them from that virus. Sickle cell disease is a classic SNP. It was put in place to help tribal members to fight off malaria. However, they don't do really well in high altitude or long distance. So that's just one example of a SNP. There's millions of SNPs. But once we know what your SNP is, we'll know how we can support it, whether that is a change in lifestyle, avoid this food, eat this food, take this nutrition, or do this exercise. And that's kind of why it's important to look at what are we really made of and what is our risk factors that go along with it.
Yeah. Okay. So I've always heard lifestyle is 80% of the equation and genes are just 20%. So I'm hearing from you, you can actually do something if you know what your genes are to prevent them from expressing. But if I'm kind of going along with, all right, lifestyle is 80%, can I just work on that 80% and make sure I'm eating well and sleeping well and all the other lifestyle things? Or should I still know what my genes are?
Well, I'm sure you can do that. And I think it's more like 90-10, 10% of the genes. But that's 1 year. 1 year. So let's say the next decade, you went from 20 to 30 to 30 to 40. Is it still 90-10? No, that 10% starts to have more and more of a weight to it. And some of the new applications or software that we've even come across. So let's say somebody has all the genes for whether it's Alzheimer's, Parkinson's, or even heart disease.
Mm-hmm.
When you're in your 20s, your risk factor, even though it's 90-10, are showing up at 1 in 100. You have a 1 in 100 chance. And all of a sudden you get to 30 and it's 1 in 50. And when you get to 40, it's 1 in 20. And when you get to 60, it's 1 in 2, because you have all those that are there. So statistics can be moved around here and there, but what you have is what you have. And if we support it the right way, maybe we can push that out to when you're 60, it's still 1 in 50. That's the whole premise of looking at your genes, is to see what can we do to prevent this. In the medical world, the medical model, and I worked in that world for long enough, we have to wait until you have a disease until I can do anything about it or call it something. I mean, we might say, hey, get some exercise, change your diet, your cholesterol is borderline high, but you don't have cardiovascular disease.
Yeah.
Well, what are you going to do about that?
Yeah.
We know now with your genes what we can do to help push that out even further, if not prevent it.
Okay. So what you're saying basically is, as you age, the risk of the genes you do have grows, but there are things that you can do early to prevent it. So it is actually worth knowing.
Absolutely. And that's just not just knowing for you. If you have any children or grandchildren or great-grandchildren, it's finding out where they come into it as well. Because if both parents have a particular SNP that isn't working well, the kids are going to have it.
Yeah. And
let's say the kids have a grandchild or a great-grandchild, and they all have the same thing. You're just passing this along. And of course, you're adding more and more genes that might be more and more SNPs that add to the equation. It's not just so much about the highlight gene is called the MTHFR gene.
Yeah.
But we look at least 59 other factors within the MTHFR. And my premise with this was that too many of my colleagues were jumping in and supporting the MTHFR when they hadn't done anything for the detoxification process of that, when they hadn't done anything for the digestive system for that, when they hadn't done anything for the energy. And a lot of these patients were getting worse. That's because the body didn't know what to do with it. So we want to look at the whole process, and it's going to show up differently. So for instance, I have an 83-year-old man who has peripheral vascular disease. He has the one form of the MTHFR plus a few others. Both of his sons have cardiovascular disease and high blood pressure. Both of their sons have had 4 or 5 shoulder replacements, knee replacements, hip replacements. These guys are in their 30s, and this started when they were 14, so it's a joint dysfunction. Okay. And their kids, or the great-grandkids, are either autistic or Asperger's. Okay. Same gene, different expression. But now I understand where it came from. Yeah. And depending on who they made another baby with, we have what the relative risk is. So we usually bring in the spouses to take a look at, well, are you also carrying this too? Yeah. And how hard do we need to support or get on top of the grandchildren and great-grandchildren? Mm-hmm.
So you're saying that basically one gene can show up in each individual in a completely different way.
Of course. Of course. I mean, how many different autoimmune diseases are there? And it's 120. And that's, generally speaking, what's called a vitamin D receptor gene. 120 different options, not to mention how many different virus susceptibilities or fungal susceptibilities or yeast. I mean, it goes on and on and on just from one gene.
So what I also hear you saying here is that autoimmunity is connected to a gene.
Absolutely.
VDR.
At least that one. There's a few others that go with it.
Interesting. Okay. So I think most people these days have heard of the MTHFR gene. And what I'm hearing you say, and I want you to talk more about this, is it's not as simple as, oh, just take some folate or some B12, methylated B12.
Yes. That's where I jump up and down and get on my soapbox and say, please stop. Please stop. And if that's what we're doing, then you don't, it can be a detrimental effect. For instance, There are just little supplements you can get for energy that are B vitamins, or something you can put in your water that's a B vitamin.
Yeah.
And too often people feel like they have anxiety or maybe a little depression or some nervousness or even nauseousness.
Yeah.
And that is some symptoms that B12 is inappropriate for them. B12 comes in at least 4 different forms that we know of, and there are multiple companies that have different cofactors that go with it.
Yeah.
And I explain it in a way that this B12 or folic acid or folate, depending on what process you're looking at, is sort of like an orange. If you eat an orange, the outside of the orange, that white stuff, is called ascorbic acid, and that is the cofactor that activates vitamin C.
Mm-hmm.
It is the same with folate or B12. We have cofactors that make it work. So just taking it by itself may not be of use, or might be worse. It's toxic to the body. So we have to know what cofactors or what absorbs it. So there's 2 other genes that come along with the MTHFR. One's called MTR.
Mm-hmm.
And if you have the MTR SNP, that means that you just eat it up as fast as you possibly can put it in. Okay, that could be a problem. Or if you have the MTRR, it is supposed to activate the B12 so that you can use it to detoxify or to reduce something called homocysteine.
Yes.
So in the MTR, homocysteine will be very high, but in the MTR, homocysteine really doesn't change. However, they have increased risks for blood coagulation and inflammation.
Okay. So when you're working with your patients, it sounds like what you're doing is you're looking not just at MTHFR, but also MTR and MTRR to determine what form of B12 they actually need.
Yeah, I hope we can see this. I have this little chart. I'll try to do my best here and bring it up to the screen. But if you can see on here, and this is just for B12 and folic acid. One of these up here is called a COMT V158M. That's a type of gene. And then this VDR TAC gene. And each one of these things down here, whether it's plus minus or plus plus, I know that's terrible, tells us based on your genetics what form of B12 I should use. So for instance, there are people who take B12 or get B12 shots and they have no change. Well, did the body just use it up? If they had the MTR gene, they would have. But what if it's the wrong type? They can't absorb that type. They have to have a cyanocobalamin versus a methylcobalamin versus a hydroxycobalamin. Yeah. We don't know that specific until we know what your genes are.
Interesting. So you actually, when you're working with someone on their genes, you use their genes, it sounds like, to determine what supplements they should be taking.
Correct.
Okay. That's pretty cool. So one of the benefits I'm hearing of learning about your genes is not just, hey, it could help my kids and my grandkids know what health things are going to have to deal with or potentially deal with and ward off, but it would help direct your supplement plan and what you choose to focus on.
Correct.
Cool.
So the other part to that is if let's say somebody has what's called an ACAT gene, and that would be what makes this thing called acetyl-CoA, which is the bounding block for cholesterol, or when we get to what's called ApoA and ApoB genes, 1, 2, 3, 4, 5. If you don't have that, you're not going to make cholesterol properly. They're going to make too much of it. It's not going to go make hormones. It's not going to go make energy. It's going to cause brain fatigue, et cetera, et cetera. And even if you have the MTHFR, we have to start on what makes energy. Yes. So that's a supporting mechanism. I mean, there's a process to go through. We don't just hop in on what you really need at the end game. We have to make the body work. And when we make it work, sometimes some of these other things that you would show from your genetics that you would need, you don't need them anymore because your body's working. We want to make your body make what it needs to work.
Cool. All right. So it sounds like when you're looking at someone's genes, it's almost like this puzzle, and you're able to kind of put some pieces in place to make it work better than it was before.
It's a puzzle.
Yeah.
It's a puzzle. This is a terrible picture. I'll show you this. This is the metabolism puzzle on the human genome.
All right. That's a whole lot of biochemical pathways.
Yeah.
It's a little fuzzy, but I remember from all my classes, I know what that is, and it makes my head spin.
Yeah, I'm still working on it. I have to go back through and reread some things because not everything's stuck.
Yeah, it's
but
complex.
but it does come back out and say, oh, okay, this is why it, for instance, if somebody had a gluten sensitivity,
Mhm.
um, it can be the MTHFR. It can be the VDR because gluten can lead to Hashimoto's and other things, or it could be leaky gut, or maybe they have an autoimmune condition, so that's an HLA gene. But there are what's called HNMT genes that make histamine. And if you're making histamine, you're creating more leaky gut. And
Yeah.
so let's say somebody had every single one of those. We're never going to be in the gluten world ever again. But let's say you had one of those and we could support it. Now, there's no literature that says we can ever fix any leaky gut, but I have enough patients now that have been gluten sensitive and have had Hashimoto's and have had celiac that are being exposed to gluten without the side effects because the body can tolerate it.
There's some hope for a few people that they
There's
could
some hope for a few people.
gluten again.
Yes.
And
Yeah.
you would
But
be
I
able
need to know your genes to
yeah,
help you make that
you need
decision.
to know if you're safe going into those waters again. That's pretty cool.
That is pretty cool.
You could have a pizza on occasion and not worry about setting yourself back too far. That's nice. Okay. Well, we talked a little bit about the MTHFR gene and MTR, MTRR, and that's the one most people know about is MTHFR. Is there another gene in particular that you think is just really critical to know about?
Well, in our world, I'm going to go out on a limb here because we end up testing people who don't feel well.
Yeah.
And most of the patients who come see me we just call them, they're sick and tired of being sick and tired.
Yeah.
And they're sick and tired of being sick and tired because something has gone awry, but they don't have a clinical disease yet.
Yeah.
And most of these are autoimmune or subclinical autoimmune. They have antibodies, and that's called autoimmunity, but they don't have an autoimmune disease yet. So they're pre-autoimmune, I guess you could say.
Yeah.
So I do look at what's called the vitamin D receptor, or the VDR, because of the autoimmune condition that goes in there. Also, if somebody is aging much faster than they should, I mean, if anybody's gone back to their high school reunion and looked around, well, that person really aged, and that person, there is that. Well, those people are not, they're not making something called superoxide dismutase or nitric oxide synthase, which means they're not detoxifying themselves in a particular pathway called oxidation. We all oxidize, so we need to make something called an antioxidant internally. Your body makes this thing called superoxide dismutase or catalase or nitric oxide synthase that makes all that happen. So we definitely want to look at that. Any cardiovascular event, you have to. Anybody that has Hashimoto's, this thing called tissue peroxidase or the TPO antibody, that is an insufficiency in that pathway. So we want to support that. So those are my big two. But if you turn on the TV and ever watch a commercial, they'll talk about Mao inhibitors.
Yeah.
Well, Mao is what VDR goes right into. So it's not that the medical world is oblivious to this. They're using these genes to create a medication to either block it or go upline with it. Any type of cholesterol medication is for the ACAT gene. They want to stop the process of making more and more cholesterol. So we're following everything that goes into the medical literature or what goes into PubMed. We're not pulling any rabbits out of the hat. Everything has to be some sort of science-based. The only thing when it gets into some, we'll call it some tricky genes, or you have this particular thing, but the only research on it is, let's say, Japanese men between the ages of 60 and 65, and you're not a Japanese male. We have to use some common sense, but also, well, if you're exhibiting the same symptoms, then perhaps, even though you're not Japanese, we'll have to take that into consideration.
Right. So you're able to basically use supplements and some natural means to make some changes to these gene pathways so that you work better. You don't have to go with a prescription like you see on TV.
Correct. Okay. But that's also what blood tests are for.
Yeah.
So we can use simple tests, what's called a CBC or a CMP. We look at homocysteine, even your antibodies for your thyroid. Yeah. When that VDR starts to work better, or if anybody's ever had Epstein-Barr that's sitting on here or known of somebody who has Epstein-Barr, it's kind of hard to get those antibodies to come down until we started looking at gene support. I wouldn't call it gene therapy, but it's genetic metabolic support. And all of a sudden, the body started to function or process better, which means that those inflammatory causes start to go down.
So most of the people that I get to work with are autoimmune. And they hear me talk about, probably every visit, they hear me talk about, looking for root causes of like what's driving their immune system crazy, what's making the immune system attack them. So we talk about things like finding foods you're sensitive to, or do you have a hidden infection, or is your blood sugar, out of control, or your hormones fluctuating. We go through things like that and try to identify are they there, they're a problem for each individual, and if they are, we make a plan how to correct it so that it takes some of the strain off of the immune system. So we've been talking about roots, but from what you're saying, it sounds like for anyone who's dealing with an autoimmune issue or even a cardiovascular issue, that genes are a root that they can explore, and maybe it can help shift how they're feeling.
Absolutely. But that said, you still need to have the infection taken care of. You
Right.
still need to know what is underlying, because those are environmental factors that play a role in expressing whether it's the gene that we're dealing with or a gene further down the road.
Yeah. Okay. That makes sense. So it's something to add to the list of roots. You can't ignore the other ones, but it's something you want to put in there and look at
Absolutely.
all the others. Okay. I've heard you mention something called the party gene. I was going to see if you would talk about that for a second.
Okay. It's really hard to find this in the literature. My background is pathology, and so for whatever reason, I get to go into the back end testing, like with Quest and LabCorp, when they put together little seminars, and I sit there with pathologists, even though they know that I'm not. So when this is probably in 2003, 4, when they really started testing the ApoA gene, the ApoB gene, and looking at how those process, they came up with what's called the genotype. How are you expressing? If you're, and they only really show 3 different types, whether it's 2, 3, or 4, and it could be a combination of either one of those, whether it's 2, 2, 2, 3, 3, all the way up. And so nobody's ever talked about this 1, 1. That's
Oh,
because it doesn't make any money.
oh,
So with 1, 1, if you're Apo 1, 1, when you drink more red wine and when you eat more bad foods that are fried,
yeah.
your cholesterol actually improves. Your C-reactive protein, which is an inflammatory response in your arteries, improves. Your homocysteine improves.
Wow.
By the way, that's less than 1% of the population.
Okay.
So there's
You
no money to be made in the medical world.
Yeah. If
Yeah,
you've got that one, you've hit the lottery and you can just party.
yeah. I've never seen one clinically. I just it had to come up as they have to throw out anomalies that happen.
Yeah.
But they do call it the party gene.
Some guy who's been drinking and smoking and eating terrible food his whole life, and he lives till he's 90 and he's fit as a fiddle the whole time. And so maybe those are the APO ones.
It could be. They also might be the master methylators. Their MTHFR and the MTRR and MT
Yeah.
are just fantastic and working fine. I have an uncle, Mike. He's 70 years old. In my entire lifetime, I have never seen Uncle Mike eat anything. We would go there for Thanksgiving or Christmas. He would have a pack of cigarettes and a coffee. Never saw him eat or drink anything else. The
Wow.
guy was as fit as you could possibly be. He never had a spot of gray hair in his 70s.
Wow.
And the best I could say is he had the most awesome detoxification and superoxide dismutase system to clear out all his free radicals, because he's bombarding himself every single day. And
Mm-hmm.
it's not slowing him down. But I'm not him.
Yeah. It all depends on which genes you inherit,
Yeah.
and there are a whole lot to choose from.
I've got the, if anybody's ever seen the movie Twins, where there was Danny DeVito and Arnold Schwarzenegger,
Yeah.
I got the Danny DeVito genes.
Yeah. So those are all really kind of helpful things to think about. I've got a few people who've sent in questions they want me to ask. So if you
Okay.
don't mind, I'm gonna hit you with three questions from some of the New Leaf people. I have someone who says her main question is about MTHFR and the link to autism. She says she has a 14-year-old daughter who's high functioning Asperger's, and she wants to get her tested, but her daughter's just terrified of needles, so she hasn't. And she wants to know, the connection of MTHFR to autism, because the mom knows she has the 677 is heterozygous, and so is the 1298. So she's wondering about that, and she thinks her husband, the girl's dad, probably has Asperger's as well. So
Okay.
she wants to know about the link to autism, and then what test would be the best to figure out what to help her daughter with in terms of supplements and diet.
Okay. Is the mom the 677 heterozygous and the 129? Okay.
Yep.
So the only way we've got a 50-50 chance on what your daughter has at that point, because she's going to get one of those. I don't know if she's going to get the positive or negative or either one of those, or what the father has. So we wouldn't know until we tested your daughter.
Yeah.
The good thing is that we haven't used needle genetic testing or blood related testing for about 4 years now. We still have those. I do some spot tests for BRCA1 and BRCA2 if I needed a specific gene, or I've got a couple of muscular dystrophy in the family, or husband and wife have muscular dystrophy in their family and want to make sure that they're not both just going to add to their family on that. So, but for this, no, it's saliva.
Good.
It's a spit test, and it doesn't take that much. The longest anybody, even when in the worst case Hashimoto's, it wasn't making any saliva, I think it took her 10 minutes.
Okay.
So it's not hard. But if the mom has the MTHFR 677 heterozygous, she needs to be evaluated for homocysteine. If the homocysteine isn't high, perhaps that gene isn't really going. Okay. On the other side, it's kind of funny because the other part of that gene, the 1298, actually reduces homocysteine. But when you have a heterozygous gene, you still function at 70%.
Yeah.
When it's homozygous, it goes down to 30%. But in this case, I would look at something called BH4. This is your get out of jail pathway and gene, that when those aren't working, something else has to kick in. And I explain it to my patients as, well, there are two types of oxidative stress. Running down the street and I'm talking to you and I'm having aerobic respiration. And then a lion jumps out and I'm going to try to make sure that I'm faster than you. And now I'm in anaerobic respiration. So that's what the BH4 pathway does. It's our get out of jail. It's our backup pathway. But some people might have the BH4 too. And so that can lead to neurotransmitter loss. With the Asperger's, I'm going to guess that that's probably shown up. Okay. And then ammonia increases. So people that have Krebs cycle dysfunction, they can't make energy. Lyme's disease, allergies, all have ammonia. It pops up in different parts of the cycle. So we want to take a look at that. If both parents pass along those two things, then we have a big the neurotransmitters just don't get made, or one of them gets made and over. It's made so much that it causes high functioning is fine, but I'm guessing that there's overactivity or over concentration. So it's going too much. But that has to do with the neurotransmitter, because this particular pathway makes nitric oxide. And nitric oxide comes in three forms. One of them's good, two of them are bad, and it usually goes to the brain in the bad way. That over pushes a particular mental capacity. We also have to look at with these, has there been any metal involvement? So mercury, such as any dental cavities or anything like that, or vaccinations that might have mercury in exposure to lead, and then any type of aluminum from your diet. Are they drinking it out of a can? Do they get it in their toothpaste? And the most common form of aluminum toxicity comes in the form of your deodorant.
I have heard that.
How you get it into your skin.
Yeah.
So if they have those two genes and now you're putting those things in there, that those like aluminum or mercury will completely stop it. So the question comes, because I'm just going to guess that we're going to, did this cause the autism or the Asperger's?
Right.
Yes and no. I'm on the fence. I'm on both sides of the world, medically and non-medically on this one. But do vaccines cause autism? And I would tell you that they do not. However, if you have all the genes in your body that cannot detoxify you,
Right.
and you put something in it. I don't care if it's a vaccine. I don't care if you eat out of tin cans, or if I don't care if you eat lead paint. There's nothing you're going to do to stop it. And eventually it's going to lead to a neurological condition.
Okay.
If it's not autism in kids, it's going to be Parkinson's or Alzheimer's in adults. So
Interesting.
it just matters of how it showed up. So we just have the combination of genes that have come on.
Mm-hmm.
Our collective knowledge is getting more and more. This was going on a long time. It's just now that more and more SNPs have been put into play, and all of a sudden we end up with a thing that we can call autism.
Right. Okay. So that makes sense. So it sounds like, if you had the chance to evaluate someone who's dealing with this and you got to see all of the genes that are in play, you could make recommendations that might shore up a pathway that's not working well or it's blocked, and you could get the pathways working better than they were. So you could see
Correct.
improvements. Okay.
Yep. And
Okay.
we see some really good turnaround. We haven't seen anybody completely recover from Parkinson's or Alzheimer's or even Asperger's, but when you have teachers or grandparents call you and say, I'm seeing a huge difference, I don't know what you're doing, and maybe we're doing something as simple as just making the body methylate.
Right.
Because when you methylate, you protect your genes from the irreversible effects. It helps your detoxification, helps your immune support, your mood balance and inflammation, hormone balancing. I mean, there's so much with it, but we just can't jump right into it
Right.
if those aren't working.
Right.
So fix the problems and then come back and prevent them.
That sounds pretty cool to me. Okay. So the next question, we touched on it briefly at the beginning, but this is maybe of a different angle. She's asking if environmental factors play an important role in disease, and often medical professionals treat you as if you have the genes for disease, whether you do or don't. What would be a benefit of doing the genetic testing?
Okay. Well, don't mean to step on any toes, but if a medical professional is treating me for a gene for cancer and I don't have cancer, I'm going to slap them.
Yeah.
But let's say my family history is everybody has heart disease.
Mm-hmm.
Are you going to treat me for heart disease? Well, that goes against the Hippocratic Oath. If they're trying to do something in prevention, and this is the world that I worked in, and this is why I stepped out, we can't do anything medically until you actually have a disease.
Right.
It's too darn late. But from a genetic standpoint, if I know you have a very high probability of getting it, because I can see the writing on the wall. For instance, I'll take me as a consideration. I have no family history. I ran my genes and found out that essentially everything that's a risk factor for Alzheimer's, I have.
Yeah.
Awesome. This is the Danny DeVito part of me that I was explaining.
Right.
So, okay. I'm okay mentally now after the shock factor that if I get there when I'm 90, I'm fine. But from here till 90, I'm going to do everything within my risk factors to slow them down so it doesn't go when I hit 50 from 1 to 10 to 1 to 2. I want to keep pushing that out. And I'll keep watching my metabolic markers, my homocysteine, my C-reactive protein, the things that go along with it, my A1C. Yeah. And if those are out of place, I'm going to kick myself in the butt and get on them.
Yeah.
But every year that I save my wife from dealing with me with Alzheimer's, I'm saving her $200,000, which means she might be able to pass that on to the kids or the grandkids.
Right.
It's not just about the money. It's about, we've had family members that have gone through that, and I don't wish that upon anybody or anything that goes along, whether it's Parkinson's or any of that. Yeah. If I know that it's there and I can go check for it, am I going to treat you for it? No, we're going to treat you to make sure that it doesn't turn on the best we can. Right. This isn't a get out of jail that you'll never have it. But every time we push it back, you're winning.
Okay. And this touches on something you said earlier about as you age, your risk gets higher for whatever genes you are carrying. And so it does make sense to know what they are and do some prevention before you get there and maybe push it further out or even keep it from happening.
Yeah.
Okay. So basically with her question, there is a benefit to knowing the whole thing, not just like a slice or two, but the whole picture, and don't assume and just sort of treat anyway. You want to know specifically and treat very specifically.
I do.
Okay.
And it's interesting you brought that up because 2 weeks ago I was sitting with the cardiovascular group, at, whether it's MDs or DOs, and the same particular question came up about, what if we do this or we're doing that or we're treating that?
Mhm.
And so my first question back to them was, well, how do you measure anybody that walks into your door? And well, we have metrics, we have clinical findings, we're looking for symptoms, any blood tests that might be out. And I said, okay, what if there's a family history of this but no clinical findings? Do you still treat? Do you put them on whether it's a blood pressure medication or cholesterol? And they're like, well, no, that's technically outside of our scope of practice, but we bring them in more often to see when it happens, and then we treat. Okay, I'm with you there.
Okay.
I said, next question. When do most people come into your office? And the cardiologist said, well, most people come in when there's an episode or they start having symptoms. I go, I understand. So my next question to follow up to that, because we're in a cardiologist office, there's 20 doctors there. I said, what do most Americans die from?
Heart attack.
Anybody know? Yeah, heart attack.
Yeah.
What's the number one symptom of a heart attack?
Death.
Yeah.
Yeah.
It's not they come in because they have chest pain. The number one symptom of what you're telling me that you want to prevent is death. It's called the silent killer for a reason, but yet you're waiting for everybody to come in with symptoms before you do anything about it. I said, I think you can see where I'm going with this, that prevention isn't just doing something you think might be there. You have to be better than that. You have to do more.
Yeah. Okay, good. This is the last question from a patient, and then after that I want to ask you about some testing,
Okay.
how to actually get the test done. So this last question is just, I'd like to hear a little bit about the APOA2 and the APOA5. And that's the first question. The second question is, how can a non-medically savvy person interpret her own genetic testing results? So those are the two last questions.
All right. Well, APOA2, APOA5, I mean, I just kind of put them in the same group because ApoA, whether it's ApoA, ApoB, it has everything to do with how the cholesterol is made, which means it's going to have everything to do with cardiovascular health, which is going to be everything to do with energy. Also hormones. Your hormones come from cholesterol.
Right.
There's a difference between the size of the particles. If anybody's ever heard that your LDL cholesterol is bad and your HDL cholesterol is good,
right.
Throw that out of your brain. Just get rid of it. It's size.
Mm-hmm.
Big particles, whether they're HDL or LDL, good. Little particles, bad. Yeah. So each one of these, whether it's ApoA2, there's also a 3, a 4, and a 5. Each one of those are a risk factor. Mm-hmm. The more you have, the more risk you have. And we're still going to look at metrics as the cardiologists do. What's your blood pressure? How is your C-reactive protein? Do you have really big red blood cells? Because that means that your B12 and folic acid aren't going along, which means you're probably going to make something called homocysteine, which affects brain function and cardiovascular function. So the more you have of those, the more risk factors. But here's the deal. If your blood tests are still wonderful and you still have those risk factors, I mean, we're not going to tell you to go act like you have the party gene.
Yeah.
But we get to watch this before we really have to get on top of it. So how can a non-medical person read their genes? Well, you probably should have a report. And I'm going to show you what a basic report is. And I would hope that anybody can understand what this is, assuming that you're not colorblind, because I don't know how to help you on that one just yet. So a report looks like this. And all you have to see is there's genes over here, and then there's this color: yellow, green, and red.
We all know what those mean.
Red is bad, green is good, and yellow means we might have a condition. So of the 200,000 genes that we are looking at, and by the way, when we get a gene printout, it looks just like this, and we get about 1,000 pages of it.
Wow, that's crazy.
That's no fun. So that's why we have software. It gets in there, and then we're looking at 60 of the main genes that make the body function. Actually, they're the genes that make the body function. I'm not looking specifically for one that would cause breast cancer or ovarian cancer or liver cancer. That's a totally separate thing. Wow. These are what makes the body work. And without these, you do end up with those clinical diseases. So the red and the yellow and the green with your symptoms, with your blood tests, is how we can put it together. And all you have to know is red is bad, green is good, and yellow we kind of watch. And that might tell us we need to run some blood tests, or even it's a urine test, or, you don't really have any symptoms on this. So we're just going to make you aware of it. If all of a sudden you have eczema, which is what this gene does, we need to do something about it. But if we can support it in a different way and make your body take care of it,
yeah,
I'm okay with it.
Okay, cool. And that brings me to my next question is, I've always heard to get your genes tested through 23andMe, but I'm hearing there's been a change recently in the world of gene testing. So is that still the best test to get, or would you recommend something else?
Well, we used 23andMe for about 4 years. Mm-hmm. I'll give you the background of 23andMe. They were brilliant on how they did it.
Yeah.
They sold to a pharmaceutical company who now markets to the people who have 23andMe. Okay. And in our office, I don't want my patients to be subjected to that. On the other side of that, some of these genes, like the ACAT that makes your energy for cholesterol, have now been taken out of the 23andMe testing. I need to have that. Your VDR is no longer tested in 23andMe. Oh, really? If you're autoimmune, I need to have that.
Yeah, for autoimmune.
So as of December of last year, I fired him.
Okay.
There are 8 other companies, but the best one that has, they're called plates. They put them on these plates, they put your genes on it, and they run it through there. We don't need to go into the details of that, but the best plate out there is out of Miami right now. The cost on it is not acceptable. So you're still looking at $2,000 for a genetic test as it stands now. I do get a few more SNPs in there. They give me about 30 more. We have run one. We've run a pseudo test on there. Mm-hmm. If somebody has a real clinical case where they seem to have every single symptom and disease state, we might go that route. For everybody else, we are currently using Ancestry.
Okay.
And if somebody's had an Ancestry test in the last 6 months, you're still okay. If it's been beyond 6 months, that chip that they used has now been updated. And probably about every 6 months, there will be a new one. That's the way it's going, which means we get more information. So, for instance, I took this off of one of the old chips, but you'll see there's this big thing of white stuff here.
Right.
It says not tested.
Yeah.
So while our software has now been upgraded to find all those, the only one that's getting close to it, and of course they don't do all of them, is Ancestry, and it's quite affordable. And if somebody already has theirs done again in the last 6 months, we can take that and drop it into our software and then go through everything else we do with them.
Okay. Do you happen to know what the cost is on the Ancestry test?
Ancestry test, we get them for $90. Okay. Somebody wanted to have their whole family, you can get on there and get coupons.
Okay.
Somebody doesn't want to buy their kit, we'll get it for $90.
Okay.
It's okay.
Yeah. So do your patients get the test ordered through you, or do they go to Ancestry directly?
Well, the easiest thing is that we do it in office, and here's why. Okay. There's a back end setting on there that has everything to do with that raw data sheet that I had. That's 1,000 pages.
Right.
For the first 6 months, we tried to give instructions on how to get that. And here's what happened. 6 months later, somebody would say, hey, you got my genetic stuff yet? And I'm like, well, you're supposed to send it over to me, and it wouldn't happen. Okay. So while you have access to all your DNA and where you came from and all that fun stuff, we'll just do it for you. And once we have it, you can change your password. You can do whatever you want. You can go meet your relatives if you want to. We turn off everything in the beginning. We don't want you to be because they will advertise to you.
Okay.
But you can opt out of all that. Or if you don't want to meet anybody, long lost relative or somebody you didn't know you're related to, we turn that off too. And that's totally up to you to go do on your own. But I just want the raw data. And when we get the raw data, we dump it into our red and yellow cycle, and then I look into I have what's called an interactive program. I'll show you a few of these. These are all the genes that we were talking about. Anything in purple.
Purple spots.
What's there? What's that? Yeah. And so we know what supplement would support that if you had a red, or if you're showing the signs and symptoms of it, even though you're only yellow, because we know that you're only running at 70% at best.
Yeah.
And then what order to go in. So like we have 16 different orders that we go in, but the MTHFR is 16 of 16. You have to make the body make energy first.
Okay.
And so we go through that with every patient to show this is what you got. This is what how you were created, and this is how we're going to work this thing out to get to here.
Okay.
And our worst case scenarios, we're getting to the methylation in about 4 to 6 months. Our best case, and it's about a month.
That's pretty nice. That's pretty nice. And you said this is a saliva test.
Saliva test.
That's easy.
Very easy.
Okay. So it sounds like it works better if people order it through you, because you've got some magic stuff you do to make the reports come back the right way. And once you get those 1,000 pages of reports, you put them in your software so that you actually have something you can work with.
Softwares, yeah.
Yeah, then you walk them through like what these mean and how we work on getting things to work better.
Right.
Okay.
Right. We have 6 different softwares that we use right now.
Wow.
Because some of them look at PubMed, and some of them get onto Library of Congress and go through that. And then some of them use something called SNPpedia. You guys can Google that if you want, SNPedia.
Yes.
So if you have a SNP that's on there, they'll have a number called an RS number. You can just drop the RS number that you might know that you have, and it'll tell you every test, every medical research project that's ever been done on that. Cool. And for instance, I was doing that in all of mine as well. And in my past, I used to be a marathon runner. Then I moved to triathlons, and for whatever reason, my bicycle had an affinity for cars hitting it. Mm. And if I broke a bone or so, I didn't like to take medication, but I might take an Aleve just because I have a broken arm.
Yeah.
Well, and putting my information into SNPpedia, I found that my genetic profile, I have high risk if I take Aleve for gastrointestinal bleeding. My liver can't detoxify it. In fact, there's a website that we use with patients at the office if they're taking any medication that actually will show. My best one that has like little to no risk with me is ibuprofen.
Interesting.
Okay, I didn't know that. Yeah. I always avoided it because of the risk factors, but I actually have the gene for it. And I go, okay, that's only, I don't, but this is what medicine is now doing for chemotherapy. I'm not trying to push everybody to chemotherapy, but if somebody hops in and they say, well, let's try this or that, you walk out of that office and you take your loved one out of the office, you can actually go have tests run for what genes react best to what chemo based on your genes.
Yeah.
If you had to go there.
Yeah.
There's just
that about just different prescriptions, just basic prescriptions. So
yes.
It sounds like there are even more reasons than just what supplements to take.
Correct.
To know your genes. Okay. So we're going to wrap up in a minute, but a couple last little things. I mean, to me, it really sounds like there's so many reasons to get your genes. And to me, it sounds like they're so complex, you probably don't want to try to interpret them on your own. Someone like you, who has done so much of this and knows it all, could really help kind of say, this is where you got to focus, and this is what you want to take, and really get things to work better. So if people wanted to get to have you look at their gene results, what's the best way to go about that?
Well, I will be in Dallas once in April and again in May. Mm-hmm. And if somebody already had the results, then we can just grab them and take a look at them. We'll make time at your office.
Yep.
And then if they don't, then we need to get a sample and try to get it out. The turnaround time right now is between 4 and I'm going to throw this out there, 12 weeks. Wow. There's not like 4 to 5.
Gene testing is not fast.
No. Okay. No, but this time of year, now that the holidays are coming, it's getting a little faster because everybody seemed to want to have their I don't know who puts 23andMe or Ancestor in a stocking, but it happens a lot.
Interesting.
And then nobody gets around to it till February, and then it plucks up the people that are trying to use it for evaluation of your genes.
Okay. So I want to clarify to everybody who maybe wasn't on in the very beginning. Dr. Trites, his clinic is actually in Kansas City, but he's going to be in Dallas some. He's going to be with me at New Leaf hanging out. And so you have an opportunity to actually set up an appointment in my office. You can see him and go through your genes. If you've already got the testing done, you can do it. He's going to be here actually next week. So the last week of March,
Yeah.
Dallas the last week of April, and then probably again in May. We don't know yet. So you have several opportunities. You can get into the office and have an appointment with him to go through the stuff with him. And if you don't have your genes yet, we can help you get those ordered. So that's really cool stuff. That's really all the questions I had. Very interesting information and stuff. I mean, I learned more stuff every time I talked to you. I learned more stuff. So this was really, really fun. We appreciate you spending the time with us and helping us learn all this. I think it was enough fun. I'm gonna put you on the spot.
Okay.
You might want to do it again with a different topic. And what I'm thinking, you guys, I've heard Dr. Trites say there are 96 ways you can be allergic to something. And it's coming up on allergy season. And you know, allergies in Dallas are really pretty rough. So maybe we could do another webinar in a few weeks on allergies.
I think that'd be fun.
Great. Good. Okay. So you and I'll work out the details and the timing, and I'll email everybody else about that. So hang on. I've got one little thing that came up in the chat, and I just want to see. Basically, we got just somebody saying this is really informative, and she'd love to talk to you, and just thank you for taking the time and doing this. So that's
my pleasure.
Our watchers. So again, I will thank you. We're going to wrap up and let everybody get on with their evening, but fantastic spending the time with you, and just thanks so much for the information.
My pleasure.
Yeah, and anybody who wants to know how to have an appointment with Dr. Trites, just call the office, talk to Yuki. She's got his schedule, and so she can get you all set. All right, so y'all have a good evening, and thank you, Dr. Trites. We'll see you later.
All right, have a good one.
All right, bye.